Okay, good afternoon everyone. I have confirmation that we are now live, so it's welcome to this meeting of the Leicestershire Health and Wellbeing Board. This meeting is being held remotely and is being broadcast live via the County Council's website, and it will be archived so it can be viewed afterwards. Before we move to the first agenda, I'll quickly confirm the names of those members who are joining us today. From the County Council, we have Councillors Taylor and Radford. We have Mr. John Wilson. Mike Sands will be joining us. He's just in another meeting at the moment, and we also have Jane Moore. We then have from the CCGs, Faye Bayliss, Sarah Prima, Dr. Ai Howe, and we've got Laura Norton joining us to present the Primary Care Network item on agenda item 6. From the district councils, we should have Councillor Kaufman and Councillor King, and also Jane Toman. From the LPT, Rachel Billsborough. NHSE, we've got Hayley Jackson, who will be arriving slightly late. From UHL, we've got Mark Whiteman. From the police, we've got Chief Superintendent Adam Streets, but he has announced that he needs to leave after an hour. From the Office of the Police and Crime Commissioner, Simon Down. And from Health Watch, we should have Mukesh Barrett and Harsha Katecha. So good afternoon all. In fact, have I missed anyone off? Is anyone that wants to just flag to me that I've missed your name off there? I do have some apologies which I'll give. So I'll carry on. If you can remember to turn your microphone on when you're speaking and off again after you've finished speaking. If you want to speak, if you can use the raise hand button, we are monitoring it here, and also Matt will be monitoring that as well. Please do not use the chat messenger function, because obviously everything that we have here under freedom of information is available. So I just ask that we just raise our hands and keep it virtual and verbal. Apologies for I's absence. I've got apologies from Mr. Richard Blunt. Richard was a victim of COVID himself. He was struck down with it. So hopefully he's recovering and doing well. Mrs. Radford is substituting for him. I've got apologies from John Sinnott. I've got apologies from Lord Willie Back, and Simon's subbing there. Andy Williams has apologised, he's elsewhere, and I've got Sarah subbing for Andy. Caroline Trevithick is unavailable, and Faye is subbing for her. I've also got apologies from Dr. Lakhani and Dr. Barakantam, with Dr. Ai Howe substituting for him. So I would just like, if I may, to do a slight change to the order of the business. Due to the fact that Mike isn't available, I'd like to just put item 5, the coronavirus impact and response to the local care system, slightly back one item, but hopefully he should be able to join us. I hope that's okay with everyone. Thank you. I'll move on to the agenda. Item 1 is minutes and action log. I propose the minutes of the meeting held on the 24th of September are taken as read, confirmed and signed. If members are happy, I'll sign those after the meeting. We also have the action log attached, which demonstrates the progress which actions have been agreed by the board and taken. So thanks to everyone for the work on that. Item 2, urgent items. There are no urgent items today. Can I ask on item 3, declarations of interest, do any members have any interests they wish to declare in respect of any items on the agenda?
Chair, my son has just acquired a post with the NHS in the region, so I think I ought to declare that. I think exactly what it is and what part of the health service he's working for. I'm sorry, I'm not sure. All
right, thanks, Councillor Kaufman. Thank you for that. Item 4 is my position statement. Copies have been emailed you, and a version is also available on the County Council's website. Obviously, since that was published, it does have the latest figures as at this morning regarding COVID figures, and it shows that the county had a decrease of 23% over the last 7 days. That compares to 21% the week before. So great work's been done across this county, and I raise my hat to everyone involved with that. We are still high, and as you know, the decision has been made that we go into tier 3 because of the fact that we are above the national average. So, as Mike says, the work that's been done on campaigning to try and bring us back down into a lower level will continue, and I think we will get updates on that. But please do keep up the good work that we're doing there. My position statement also it highlights the campaigns that we've been doing. It also references the crucial work undertaken by health, social care and community partners during the ongoing coronavirus pandemic in order to protect our residents, local services, and in particular our most vulnerable groups. On behalf of the board, I'd like again to thank all of those who continue to manage and deliver the local response and recovery work. Also included, say, the latest figures are there, and unfortunately we are higher than average. Amongst several other things, position statement details the It's Down to Us campaign, which has seen partners working together to produce a range of comms to encourage residents to play their part in controlling the spread of the coronavirus. I think if you look at the reductions that we've seen across the county, it's obviously shown that the latest lockdown that we had, although probably not as visible as the first lockdown, it has worked. So these actions do work, and we just need to continue those messages. The push to encourage residents and staff in eligible groups to get their flu vaccinations, that's highlighted. Signposting the mental health services developed by partners as part of the World Mental Health Day and self-care and anti-bullying weeks. The promotion of our excellent weight management service, which includes a series of animated videos and aspects of healthy eating aimed at children and young people. And finally, an update on the requirement to renew and publish a pharmaceutical needs assessment, which has been suspended until April 2022. Before I move to the next agenda, can I just take this opportunity to welcome Joe Hewitt to the meeting. Joe's recently been appointed as our Health and Wellbeing Board Manager. I know Joe's been in touch with a lot of you to introduce yourselves, and I look forward to working closely with her to shape this board work. So welcome on board, Joe. Item 6. We'll now move to item 6 on the agenda, because I'll put 5 back just to wait for Mike to join us. This is a report and presentation concerning the primary care networks across Leicester, Leicestershire and Rutland. In the agenda package, pages 21 to 40. Sarah Norton from the CCGs will now talk us through the presentation slides, which provide an update on the networks which were introduced in the summer of 2019. So if I can, I'll hand over to yourself, Sarah. Thank you.
Hi, Chair, it's Laura, but no worries. I've been called worse, just in case we get anybody confused at any point. Thank you very much for the introduction. If it's okay with everybody, I will whip through the slides that everybody's seen in advance, and then I will give some time at the end for questions, because I'm sure members might have questions about how primary care networks are working currently in the different areas within the county.
Sarah, I apologise. I did call you Sarah, but it does say that on my notes, so I do apologise. Laura,
absolutely, it's not a problem at all. I've heard far worse, so don't worry about it. Thank you.
It was polite.
It was very polite. Okay, can everybody see my screen?
Yes, I've got it here. Okay,
lovely. So primary care networks, as you mentioned in your introduction, have been around for about 18 months within the NHS. They were enshrined initially within the NHS long-term plan, and then the investment and evolution plan for primary care and general practice. What a primary care network is, in effect, is a group of GP practices working together over a patient sort of list size of around 30 to 50,000 patients. Now they work geographically, they're geographically aligned, and they were developed with the aim to give GP practices more ability to work strategically and at scale together and have a larger voice, and to become more sustainable and take on additional roles as time went on. We see the real benefits for them as a CCG because primary care networks have a very good relationship with their local communities, and they have the up-to-date information about what's happening for their patients. So that's a really effective way to commission services. They also bring together clinicians from a particular area with a shared vision and an ability to deliver services together. In terms of what the local context looks like, we have 25 primary care networks across Leicester, Leicestershire and Rutland, 10 within the city, 7 within East Leicestershire and Rutland, and 8 within West Leicestershire. They're broadly geographically aligned. That's slightly more complex for the city. As you can imagine, the boundaries do overlap slightly, but within the county, we worked hard with practices to achieve as much geographical alignment as we could, and that helps when we're thinking about place-based commissioning. So we've included the contact details of your local primary care networks here in case any members are interested. But all primary care networks have elected a clinical director, and that is somebody who nominated themselves within the group. It's a clinical member of staff. The majority of them are GPs, although they don't have to be a GP, and they represent the primary care network. They take on a leadership role, and they represent primary care networks in commissioning in other roles. So that's who we tend to work with as our team, and their names are here. So in their infancy, the first initial year of primary care networks was very developmental. They had to develop their organisational structure and their governance, elect their clinical director, and sort of get used to working together, how money would flow, etc., between them. They're all very different. They reflect their different communities, and they're at different levels of maturity. So as a CCG, we've been trying to work with the primary care networks on their organisational development to make sure that we are helping them all to move forward at pace and to maximise the opportunities that are presented to them. Now that they are growing as organisations, the expectation is that they are taking on more services and they're commissioning more things at a primary care network level than an individual GP practice level. So one of the things that they've been doing is taking on new members of staff, and these members of staff will work across the PCN footprint to deliver services. So they have recruited clinical pharmacists, they've had funding for this, social prescribing link workers, physiotherapists, physicians associates, and that is going to increase over time. They will have more of a budget to recruit additional staff. Now they will work slightly differently across each PCN, but the practices will utilise them to do developmental pieces of work, or, in case of pharmacists, maybe medication reviews or seeing patients face to face across that. And they are developing larger teams as time goes on, and that helps them to deliver various services. So this year they have been, COVID aside, which has undoubtedly sort of stopped things moving at the pace that they were otherwise. PCNs are starting to deliver a service which is enhanced health in care homes. So that is providing ward rounds to care home patients more formally, doing multidisciplinary team meetings, and bringing more alignment between primary care networks, GP practices and care homes to try to have better outcomes for patients, reduce emergency admissions, etc. They're also doing a programme of structured medication reviews for patients. So for where patients, for example, might be on a variety of medications, the pharmacies working within the PCNs will review these to make sure they're clinically appropriate, to avoid admissions and to avoid medicine wastage. They're also doing a piece of work around supporting early cancer diagnosis. So this is obviously really important because the earlier cancer is diagnosed, the far better people's outcomes are. So this kind of work involves looking at the outcome of referrals that have been made for patients to hospital and trying to get there earlier. So increasing uptake of screening programmes and working with local communities to build those relationships and try to get people to present with symptoms earlier. In terms of next steps, as a CCG, we're really committed to the continuing development of PCNs. We are aligning our teams to provide support, managerial support and advice to them. And we are making sure that we have really strong clinical voice from the clinical directors of the PCNs on our boards and our meetings. We are continuing to focus on their organisational development to make sure that they are all able to mature and grow as individual organisations, and we're supporting them with delivery of the national specifications as I've just outlined. And I think PCNs have developed a kind of additional role during the COVID pandemic around the operational resilience of their individual members to try to provide support. And they're now being looked at as delivery vehicles for the COVID vaccine and for the hot hubs, which is a way of patients who are potentially symptomatic with COVID to be seen safely. So I hope that's a helpful overview. I'm happy to take any questions that people might have. I'll also check the chat.
Okay, thank you, Laura, for that. I've got one. I was going to say, any questions, please do use the raise hand. I've got Councillor Corfman would like to ask the first question. So, Geoffrey, over to yourself.
Thank you, Chair. You may have to remind me to take my hand down. I tend to forget these things. I've been advised that on your slide, the North Blaby bit should read just Blaby. My question is, do the PCNs work the same way regardless of the clinical commissioning group? Are they working exactly the same? And we're talking about cross boundaries. One of the OB and Wigston surgeries is in a partnership with a surgery in Kibworth, I think. Does that affect the way the patients receive the services, or does it affect the way the PCNs operate? I think it's every practice bar one, the one in Sainsbury's that's got a place near Sainsbury's, operate in the OB and Wigston one. So are patients in the other one being left out?
Okay, thank you. That's really helpful questions. I think there are two PCNs that cover Blaby. There is South Blaby and Lutterworth, and then North Blaby is with kind of Enderby and that part of the world. So they're two slightly distinct groups. In terms of your point around geography, there are obviously different cultures and different ethoses between PCNs, and so some chose to work with some colleagues and not other colleagues. However, we are one CCG now. Theoretically, in terms of how we work together, we have one team and we will support all the PCNs equally, regardless of where they are. I would see no sort of negative effect to a patient in that who was registered in that OB practice, for example. If, than being in the other PCN, we try to make it all the same, and we're engaging with the district councils around that. So I think that it's one of those things, and I don't think it's detrimental to patient care.
Okay, thank you, Laura. Next, I've got Deborah Taylor.
Thank you, Chair. Just a quick question about schools and how there's going to be, I didn't see, unless I missed it within the overview, about any connections with sort of schools. You mentioned care homes and things like that. So is there anything that these networks are doing, sort of supporting schools and, healthy eating and healthy weight and things like that?
Not specifically. I think that a lot of the policy is around older people, as you'd imagine, because that tends to be where a lot of the emergency admissions are, and that, that's where the cost is. But as things are moving towards prevention, we have the social prescribing link workers. So for some primary care networks where they have a younger population or are serving a more deprived community, it might be that they would try to use their social prescribing link workers for the kind of work you allude to. They have the flexibility to do that as it is fit for their patients.
Okay, thanks, Laura. Councillor Phil King.
Yeah, afternoon, Chairman. Afternoon, everyone. I hope you're all keeping well, staying safe, and following the guidelines and rules on coronavirus. What I got a query about, Chair, was this. When I sat through a presentation about the PCNs many months ago, one of the things that was mentioned at the time was that there would be better working relationships, coordination of activity with district councils. And we do have a health prevention role, as I'm sure Chair and others on the call are aware of. But what I haven't seen to date as leader of Harbour District Council, and in my role as representing the 7 Leicestershire districts, I haven't seen, aside from the work that we do on disabled facilities grants and that kind of stuff through the Lightbulb project, I'm not aware of any effective working relationships being established between PCNs, certainly in my area, and the district council teams that also work with, in particular, health prevention, again, across key groups. And I may be wrong about that, but I'm not hearing anything about it. So I think my point is, Chair, that if there is work going on like that, we do need to hear more about it, because moving forward, we do need to be working in a more collaborative co-production way, rather than health doing their thing in one silo and we're doing our thing in another silo. Thank you, Chair.
Okay, thank you.
Thank you. That's really helpful. I think my colleague, Dr. Sangani, might want to come in at this point just to respond to that.
Yeah, please do.
Thank you, Chair. I'm Dr. Sangani, I'm Vice Chair of West Leicestershire CCG. So I think Councillor King makes a really good point, and I think it's been somewhat variable across the patch. Speaking for North West Leicestershire, where my PCN is based, we've had really good links with our district council, and especially in the area of exercise and activity and so on. I think, to be fair, a lot of that sort of connection and links that were being forged from PCNs, which only were established in recent times, was somewhat paused because of the pandemic, but I think it's something that we're trying to foster and improve going forward. I think one of the best links we've had actually with local authority colleagues is through the local area coordinators, who've been, in a sense, our social prescribers for some time before we were able to recruit social prescribers ourselves. And for me, that's one of the most productive parts of our working relationship. But I absolutely agree with you. It's something we need to continue to do and foster and improve as time goes on.
Okay, thank you. I was going to say,
I'd be very happy to pick that up with you offline and see how we can develop those relationships locally, because I'm doing some work around this within the east of the county. So if you want to speak to me afterwards, I'll get in touch with you and we can see how we can strengthen those relationships.
Okay, thank you.
If I may, Chair, if I can just come back. Thank you for that, Laura. Happy if you want to send me an email and we'll sort that out. That's great. Thank you.
Thank you. I was going to say, Jane, I saw your hand up. Was it related to the same matter, Jane, or is it another question?
Oh, it is related, thanks.
All right.
It was just really perhaps building on Councillor Kaufman's view that, so as chair of the District Health Leads meeting, what we saw really across the piece was probably a difference between the ECCG and the West CCG in terms of the pace of rollout. So I think there was a difference. I do think that these have matured over the past few months. As you say, COVID has played its part, but I think that all district officers are certainly linked into each PCM. But there was a real difference in pace there. So hope that has a bit of context. Thanks.
Okay, thanks, Jane. Phil, do you want to drop your hand for me? Because it's just to keep my screen clear. I've got Simon next.
Thank you. Yeah, really just, I guess, similar comments and questions to Councillor Taylor and Councillor King, really, but in relation to the police. Similarly, when I first saw the presentation about PCNs, that sense of opportunity around partnership working seemed significant. And I guess just, it'd be good to hear if there's been any development around neighbourhood policing, and that they're engaged with a number of vulnerable people, which there'll be crossover there with those that's being engaged within health.
I would say, as with schools and other areas, it will be variable across the patch. And I think the difficulty of PCNs is once everybody hears about them, everybody wants them. And you have your clinical director, who's also probably a working GP, trying to make all of these relationships at the same time. And I think as a CCG, we have a facilitative role to play with that, to link you up in the particular areas, one by one. And now we are working as one team across city and county. I think it should be easier for you to build those relationships. But I'm very happy to speak to you again after this meeting, and we can start to take that forward, sort of PCN by PCN. No problem at all.
Thank you.
Thanks, Laura. Faye.
Thank you, Chair. My point was really in response to Councillor King's concern around engaging with the district councils. So I just wanted to raise that the CCGs have now set up 9 design groups, and one of them is the Primary Care and Community Services Design Group, which has actually only met 3 times. So we're in our very early stages of development, but the idea is that those system level design groups will then feed directly into the place-based governance structure. So conversations will be taken from the design group to the joint commissioning group of Leicestershire, and I chair the integration delivery group. I think the terms of reference are actually in the papers. So these are some of the things that we'll be starting to discuss, how we actually do engage at a district council level and how we really make those integrated neighbourhood teams work with our PCNs to deliver really good care for our local populations.
Okay, thank you. Simon, if you want to drop your hand, and also Faye. I've got Dr. Ihoe.
Thanks, Chair. Really well pronounced, by the way. I appreciate that. Yeah, my name is Dr. I. I'm the Vice Clinical Chair of ELR-CCG. It's just to give some extra assurance, really, about the links with local authority. Certainly I can't speak for every PCN, and I'm not a CD of our PCN, Clinical Director of our PCN, but in North Blaby, certainly there has been good links with our local authority colleagues. Certainly, we've had a section of the PCN meeting which is devoted to the wider team, including district nurses, but also there's an opportunity for local authority team members to join that meeting as well and input. We've got link workers who have also been sort of working out of practices before the pandemic, of course, which on an honorary contract, which also helped to forge those links. So although PCNs are at different levels of maturity, I think that the general trend and the desire is to work closely with the community for the benefit of patients. I think the great thing is that with PCNs is that although they're clinically led, there is a real local approach and a local focus on resolving local matters. So yeah, I think this will evolve with time, and obviously each PCN is at different stages of their maturity. But I anticipate the direction of travel is certainly to link more closely with local authority teams. Thank you.
Okay, thanks, Andy. I have no more hands up. The only comment I had was it was our page 32. It was your to-do list for the PCNs, and it was obviously there were some green ticks on there. There was just a couple that needed to be completed. So I think the business resilience for COVID-19, I think we've all been growing that as we've gone along with this pandemic, and I think we're all we are all sort of offering that to the very best of our abilities. So you've got the PCN development based on maturity matrix and the delivery of the 2021 service specifications, which I guess sort of tie up with the national service specifications as outlined. So are you happy that you've sort of done that to-do list and that is now complete?
I think that some of them are a work in progress because the pandemic has made us refine some of our expectations and ambitions. But I think, and I think there's a variability between PCNs. But with those caveats, yes, I absolutely think we're moving in the right direction, and we're working really hard to achieve consistency and forward motion across the county and city.
All right, thank you, Laura. I have no more questions or hands raised, so the board's asked to note the update. So, Laura, can I thank you for your presentation today? Can I thank members for what I thought was a useful update, and look forward to welcoming you back again to a future meeting with a further update. So, thank you. I'll move back to item 5 now, whether Mike's joined us or not. If Mike hasn't joined us, he was really going to touch on the latest figures, which were in the position statement that I drew your attention to. If Mike does join us and he wants to say a few words to us, then I'll invite him to do so. But item 5, which was the coronavirus COVID impact and response to the local care system, pages 13 to 20 in your agenda pack. The report provides members with an update on the impact of the response to the coronavirus pandemic by our local care system. And I'll now hand over to Sarah Prima, who I think is presenting from the CCGs, and also John Wilson, our Director of Adults and Communities, will also present parts of the report. So if you're happy to do that, anything in there from Mike, I'm sure we can get answers back on it as we go. So I'll hand over to Sarah.
Thank you, Chair. So for those of you who don't know me, I'm Sarah Creamer. I'm Executive Director for Strategy and Planning at the LLR CCGs. So I will take the paper as read, but I think I just want to pick out a couple of things that that I want to highlight with the board today. Obviously, as you will have known and we've just touched on, the situation has increased in terms of infection rates, etc. to get us into what has been described as wave 2, and that is what caused the second lockdown. And the knock-on effect of that for health is that an increasing number of people presenting at hospitals over the past couple of weeks. We are managing that pressure. It isn't easy, I'll be honest, but we are managing that pressure. And I think part of the way that we manage that is to make sure that collectively across the system, we're working really hard on making sure that where it's safe to do so, we can avoid people going into hospital. And when they're fit to come out, we work collectively on getting those discharges out really quickly. And as a system, we're working really well on that. So that's both across health and social care. And I'm sure John might want to just touch on that a little bit in a moment. I think the other two important things to say is that we're still in the middle of the flu campaign season. So anything that we can do to encourage people to take their flu jab is good, and I think Chair mentioned that in his address at the beginning. And then we are about to go as well, like everybody else nationally, as soon as it's available, to start the COVID programme of vaccination. And again, when those national messages are available, which we expect over the next week or so, that we collectively as a system are encouraging people to take up that vaccine as we go forward. So I think that was all I wanted to say from a health perspective, unless anybody got any questions, and I'll hand over to John if that's all right.
I've got no hands up at the moment, so yeah, thank you, Sarah. And John, if you'd like to continue.
Yeah, good afternoon. So from a social care perspective, like a number of organisations, we're in a strange place of coming to the end of our recovery phase from wave 1 whilst we're dealing with wave 2, which I guess, is helpful in some ways because it means that we can apply the learning as we go forward. But equally, it does add to the burden somewhat. Just a few things to pick out. We are continuing to have sort of enhanced engagement with providers of social care. We've got over 300 providers of social care across the county that we work with. So, there's a lot of providers. It's quite a complex picture across residential care, home care, community and day services. We've issued now just short of 60 information bulletins and guidance documents, and we meet with them on a face-to-face and, remotely face-to-face, at least every 2 weeks. There are some ongoing challenges for providers around ensuring infection prevention, control, correct use of PPE, obviously some financial challenges that providers are facing. One of the key areas that we've been working over the last few weeks is to try and identify what are called designated settings. So these are the care homes that are approved to accept people who are COVID positive, particularly people being discharged from hospital. That's proved quite difficult. We have 20 beds in the city that are available for people across city and county and Rutland. And we have 10 beds in the county which are going through approval and which will come on stream from next Monday. So we do have a bit of increased capacity coming in next week, but we are continuing to work with providers to try and get more capacity in that area. Another area that's been a concern, I know, for a number of people is the day service and community service offer. And clearly we did have to close most of that offer when we went into the first wave of the pandemic. We're trying our best now to reopen that and to get people back into services, because clearly a number of people have felt isolated, and carers require that level of support. We've got about 60% of people back into services now, and there's another cohort of people who have been reviewed and have got a plan to come back in, but we still have a number of people, probably about 30% of people, that we need to do further reviews with. Hospital discharge, something that Sarah mentioned. Hospitals are extremely busy, and we're doing everything we can as a system to try and make sure we've got flow through hospitals into community services. We have a revised pathways in place. We've put in additional capacity in. We need to continually work to ensure that flow through the system is as effective as it can possibly be. There are a number of people who through the first wave of the pandemic, up to sort of the beginning of September, people who went through hospital and into the community would have received NHS funded services on discharge. About 1,500 people are in that position, and we now are going through a review process to ensure that those people have got the right setting of care going forward and that we've got the right care arrangements in place. That will take us up to the end of March, and we are aware that that's quite a sensitive piece of work, because clearly numbers of these people will have had services delivered, and they won't have had conversations around what they might have to contribute to the care and who's responsible for their care. So those conversations are quite sensitive, but we are going through those. The only other thing to say, really, I think, is that part of the learning from the first wave of the pandemic is that we need to enhance our digital offer in terms of social care. So we are going to be bringing forward a series of proposals over the next few months, which will provide for a much enhanced offer around technology to support people at home, particularly. Also technology to support people who might be in care settings. And we'll also be thinking about actually how people access social care and ensuring that we've got a proper kind of up-to-date modern system that allows people to sort of digitally take control of their kind of their referral into care services and the whole kind of assessment process, which is often, I think, just kind of very confusing for people. So we'll be trying to make that simpler, and we'll be bringing that into a sort of the modern age, as it were, over the next few months. So that's probably all I want to say. Thanks.
Okay, thank you, John. I'm now told Mike's online. So Mike, if you're online, good afternoon and welcome. If there's anything you want to add or to the report has been tabled. So is there anything you'd like to add, Mike, before I take questions?
I'm assuming we're on the COVID update, are we?
We are indeed. Good timing.
Right. Okay. Yeah. Nicely timed. Thank you. I'm sure. Thanks, Chair. I'm sure you covered this on your position statement. But yeah, well, obviously I put a bit in there just about the numbers. But life moves on. So colleagues, I'm sure, will now be aware that the whole of Leicester is in Tier 3, Rutland is in Tier 2, the city is in Tier 3 as well. In summary, I think the situation remains the same. We've made good progress the last week. We've dropped our rates by 20%, 23%, I think it is, in 7 days, which is better than the national average, which has gone down by 21. But if we're going to get below the national average into a position where we can really start arguing to come out of Tier 3, we're going to have to go further and faster, because we're still substantially above the national average. And everything that people will have seen, the Lord Lieutenant's message, the 10 days of talking heads, the It's Down to Us, and all the work of colleagues around the Health and Wellbeing Board table through IMT and in their individual work streams is obviously all part of that. So I sort of don't have to go over a kind of IMT. Just in terms of mass testing, what was called mass testing, which is in the report as well, I'd still be hopeful that we can get that going in Leicestershire sooner rather than later, probably now, not before the sort of early part of next week. But just to kind of massage down some expectations, I think there's an expectation we'll be doing Liverpool-style mass testing, where, for a number of reasons, both logistics, standard operating procedures, legal technicalities, and a bit of an ongoing debate that we're having with the centre, much more of an issue for the city for reasons I can always go into. It's going to be the testing that we can deploy that will enable us to swamp an outbreak setting, be it a school or a workplace, or go out to selected individual electoral wards and do mass testing of a smaller area, if that's not a complete oxymoron. So that's good news, but I think we just need to sort of get the messaging right as to what mass testing means and where we are deploying it, but probably more of that to follow another time. Thanks, Lee.
Yeah, thanks, Mike. Okay, I'll go to questions. I've just got Phil at the moment, he's got his hand up. So Phil, over to yourself.
Thank you, Chair. Thanks, Mike and Sarah and Ian, for your updates. I know Mike was on the call with the Minister earlier. He's probably, like me, been trying to work out what on earth they were talking about, or perhaps he's more experienced with the verbal machinations. But what I wanted to raise was a couple of things. So first of all, I like as a leader of Harbour District Council and also representing Leicestershire districts, I think it's fair to say that many residents, the number one issue they raise with me and my colleagues is about the issue of non-COVID services, access to those, treatment by those, not just hospital services but primary care. A lot of residents are not very happy with the virtual arrangements, but I suspect they're getting used to it over time. So that's one issue. The second issue is what you spoke about, John, is about how people who did need to go from hospital into a care setting, how they've been dealt with. I haven't got experience in Leicestershire. I've got experience in another county. I have to say, didn't cover themselves in glory, and I have concerns about that. So it's good to hear that you're seeking to address that. But I suppose the biggest issue I've got is the communications to the target groups. Now, where we are now, we're all in tier 3. That's a massive disappointment to everyone, I'm sure. But to be honest, expected because of where we were. And what I think is exercise in my brain is the city's been in some form of special measures, I call it like that, since June, and doesn't seem to have made a great deal of progress from the outside. And I'm not particularly close to exactly what's going on, but if we're now all in it, and I'll put this loosely, in it together, what is the in it together that we're actually going to do to actually get out of it? Because where I am, I'm not hearing much about that and what's going to happen. And I know hopefully we're going to now get the political oversight board set up and running, so we actually understand a bit more what's going on. But it is really difficult as a district leader who isn't on the county council to actually get information and find out what's going on. I'm not criticising people. It's just a fact of life. That's what's happened. And we do need to improve those communication channels and flow of information down to people like myself and as to what's going on, because otherwise when people come to me and say, well, what is going on? You're the leader of the local council. I have to say, I don't know. You have to go and talk to the county council, and then that becomes a different gambit. So I think there are some issues. Maybe it's, but where we are, if we don't address some of these, and in particular, the one thing that's a big bugbear of mine is, it's all very interesting, Mike, and others making a video of leaders going, oh yeah, aren't we marvel? You must all win it together. But that isn't going to get the attention of a 17-year-old kid who needs to follow the guidance, follow the rules. They're just going to A, not see it, and B, ignore it anyway. So that is really where, because that's the biggest growth area, biggest area of people. The demographic group in our area, which has got the biggest case numbers. So that's my concern, is what are we doing to really focus in on the key groups we need to get the rate down? As you say, Mike, what they said earlier on the call from the ministry earlier is, don't expect anything to change until the new year. That's my interpretation, because in the review on the 16th of December, unless we've shown something going down very rapidly in the week, or basically in the next 2 weeks, we ain't going to move out of tier 3 come 16th of December. So it's going to be, New Year sometime after Christmas. So that's the deep concern that I've got now. Thank you, Chair.
So if I come back on that one.
Yeah.
So less said about the ministerial call, the better, other than sort of that's 35 minutes of my life that we're never going to get back again, is it? In terms of actions, the obvious thing to do is, I don't want to go through for hours the work of colleagues, not just my team and county council colleagues, but district colleagues as well. But obviously Norman's on the incident management team. There is just so much in there that probably needs to be said, I guess, just in terms of work streams. So the deploying the testing, which after all is not just lateral flow testing, it is all the test sites that we've set up around the county, which is under our control jointly with, your sites, plus Josh and my team leading on it. The enforcement activity across trading standards and EHOs has been exemplary. The comms is important, and there is more to it than what you've seen. There is dedicated comms working with Hinckley and Bosworth for feeding in what they've learned from the 17 to 21s. There is all the work that my team does through schools, through heads. There is the work with John and his team around social care and indeed care homes as a care sector, which we need to keep safe. There's also, I suppose, plans about vaccination, which I'll let NHS colleagues come in on as well. So I can't begin to say how much effort has been going on through my team and through broader health and wellbeing partners, working 12, 15 hours a day for 8 months now, all of which is channeled through IMT. And I think you need to get that update from Norman, and maybe Political Oversight Board would be an opportunity to showcase that and not just give you the numbers brief. So that's one bit. The only thing I'm finding at the moment is the second wave has been difficult, because we know locally what we can do when we have a baseline load, but then things bubble up, and we achieved that twice in Opium Wigston, we achieved that in Melton. The second wave, I think, has stretched all of us, and it has been a fairly dispiriting couple of months for me to put in the effort that we've always put in, but actually still be powerless to stop the numbers going up. I would hope by December the 16th that as our numbers go down, we eventually get to the stage where, if you like, we see more disparity across districts in their rates, because we're back to the land of 1 or 2 or 3 districts which have a bubbling up of rates, and then we can take the action that we are, but actually it has a more concrete effect in turning things around, instead of trying to be a bit of a King Canute trying to stop a tide, which we've been absolutely sort of powerless to do the last couple of months. But I say that there's a lot there, and maybe Political Oversight Board is worthwhile doing a bit of a work stream update, just to give you an overview of the work that does go on every day.
Okay. Phil, if you're coming back, sorry.
Yeah. Well, first of all, Mike, I'm not disparaging anything your team, everyone in the third health service, social care has done. Everybody, every public sector worker who's involved in this and beyond has worked their socks off. I absolutely acknowledge that. I don't disagree with you. The commitment that's been shown, the additional hours, the sacrifices that many people have made, both in terms of themselves, their families, their own personal situations, has been beyond the call of any employee duty that I'd expect to see from anyone. So I'm not disparaging that at all. I just think where we are now, it's clear there are 1 or 2 things that where we need to really focus in. And as you said, we've got to get the rates down. We need to get it down quickly. So we need to be working, much more we need to be looking at how we can do that, I suppose, in a more laser focus, if that's possible. I don't know if it is, but that's just my interpretation from where I am, which is obviously not in your role, Mike. I'm just on the outside to some extent.
Okay, thank you. I think it's interesting. I think the Down to Us campaign, it was people were almost getting blasé, and they were getting the same messages over and over again: hands, face, space. And I think it was a case of trying to revitalise that. And I think it was from the top down. I know the 6 leaders, the video that was put out has been viewed over 650,000 times on Twitter and Facebook. So it is getting out there, and I think that's being cascaded down. I think the Lord Lieutenant, the chairman, I think there was a call for faith leaders, GPs. I think they were looking at youth councils across the districts to do messages as well. And I think a call was going out from the comms team to all district councils and their youth councils to say, post messages, because people are listening. But it is the same old message, and I think we keep after saying, and the message of, I think it was 10 days to save Christmas. I think to a point 10 days is Christmas is saved. I think the actions that have been taken may cause us a problem in January. But I think the work that we have to keep on doing is keep pushing that message out. And for it to go down 23% in the last 7 days across Leicestershire is a fantastic achievement, and 21% the week before. And, as I said before, people moan about lockdowns and it's not fair, it's not working, but it clearly is working. And it's a shame when districts go up and you have to try and understand, which is obviously what Mike and his team do. So to take on board what you've said, Phil, and thanks for your answers, Mike. So I've got one more question from Jeffrey.
Thank you, Chair. Talking from a district perspective, and from probably, I suppose, Opium Wigston say we lead, others follow, but we're not really boasting about that these days. It is the belief amongst Obi and Wigston councillors that the problem is in the school, not in the schools, but the pupils being collected to and from the schools, the way they travel, the way the parents gather outside the schools. And if there's going to be any particular effort, it's got to be on the transport of and transmission of kids to and from school. That's our local belief and observations. We have a lot of schools with a lot of pupils in the Opie side of the borough, and that's what we are seriously thinking. And if we've got any resources or anything to be done, that's the way, because with the schools open, I fear that this month lockdown is a bit wasted, and a lot of businesses fearful of going out of business and a lot of aggravation, but we're doing it with one arm tied behind our back by the government. So if you've got any resources or anything, it's the teenagers, and it is also doing something about the arriving and leaving of schools.
Yep, so thank you for that. I know it was raised at all member briefing on Tuesday, and Jane might want to comment, but we did feed that into discussions between myself, Jane Moore, Anne Carruthers in Environment and Transport, and district colleagues. I think Obi and Wigston and Blaby, Jane, correct me if I'm right, were the two that volunteered, if you like, to stand up in enhanced enforcement or at least observation around school gates. So the intel is always useful. I don't know if Jane would want to comment further on that.
Yeah, I can just add in, we've raised those matters at the education cell. I think just a couple of things really. One is that we absolutely appreciate there are concerns about children moving to and from school and indeed around school. But actually some of the concerns are about what goes on within the home environment as well, and where children are mixing within the home environment. So I think it's a mixture of messages, isn't it? We're doing a huge amount of communications out with our school partners. Schools are doing their utmost to manage the kind of rates of transmission within schools and keep schools safe. It's really important that children can remain in school safely, and schools are doing absolutely everything they can to kind of manage that. So there is a mixture of communications. As Mike said, some of the targeting, particularly for young people in understanding, but equally for parents and carers as well, around how they're managing children who are self-isolating or indeed after school as well. So it's something that we are aware of and are addressing with our education colleagues as well.
Okay. Thanks, Jane. Jane Toman, did you want to add anything, Jane, regarding what Mike mentioned earlier?
Oh, nothing really to add. I mean, the IMT, the work that we're all doing collectively with all partners, just doing what we can really. So I think points noted, and I'd say we're on it. So it's down to everybody really, isn't it? Thanks. Okay.
Thanks, Jane. Thank you. Okay, I've got no more questions. Jeffrey, if you'd like to lower your hand just to make it easier for me in case you've got another one coming up. Can I thank Sarah, John and Mike for your sort of presentation, your report, and also the answers given. So can I thank members for the questions? The board's asked to note the report and the update. So thank you for that. I'll move on to item 7, which is the development of a healthy wage strategy for Leicestershire, pages 41 to 70 in your agenda pack. This provides the Health and Wellbeing Board with the opportunity to comment on the draft strategy. It is now out for consultation. So Liz Orton, our public health consultant, has joined us and will present the report. So over to you, Liz.
Thank you, Chair. So something different now. As you know, I'm sure you're aware, overweight and obesity is a significant public health problem in Leicestershire, with over 2/3 of adults and 1/3 of children by year 6 being overweight or obese. And we also know there's quite a steep social gradient with obesity, so it's more common in areas of more disadvantage. And now we can see an emerging connection between obesity and an adverse COVID-19 disease as well. So particularly important at the moment to be looking at this. Last September, there was a joint strategic needs assessment chapter published on obesity, healthy weight, nutrition and physical activity. And one of the recommendations from that was to develop a healthy weight strategy for Leicestershire. So obesity, as I'm sure you appreciate, is quite a complex problem. There isn't a simple way kind of solve obesity, and it will involve a combination of both top-down approaches from central government, but also bottom-up approaches, looking at what we can do in our local communities, and also working across sectors, so we all bring our own areas of responsibility and expertise into the picture. And so we've developed a draft healthy weight strategy that looks at those different components of how to address obesity, and we've come today to seek your feedback as part of the consultation, which will carry on until the end of December. I hope you've had a chance to look at the draft strategy, but I'll really briefly go over the structure of it, which is to have 3 key themes. Theme 1 is looking at the action that we can take to address what we call the obesogenic environment. So that means the environment that is conducive to people gaining weight and maintaining a higher weight. And so what we want to do with this theme is to ensure that people have access to healthy, nutritious and sustainable food, and that settings that we live and work and go to school in and experience every day are designed in a way and kind of set up in a way that makes making healthy choices easier. So that's the environment component. The second part is to look at the very specific weight management services that we have available in Leicestershire, and this is both with the public health, healthy lifestyle services that we have at the county council, right the way through to the very specialist weight management and bariatric services that are in the community and at UHL. And then the third part of the strategy is to look at all of us as system leaders and what we can do to improve both the workforce's ability and confidence to talk to people about their weight and to offer the correct advice and guidance, but also to look at our policies and to ensure that we have healthy weight policies, so policies that are conducive to healthy weight rather than adversely affecting weight. The consultation, as I said, will run till the end of December, and this is part of it. There's also an online form that the county council website, you can be directed there to provide your advice. We're also doing some very targeted work based on the Equality and Human Rights Impact Assessment that we've undertaken, looking at specific groups, particularly those with disabilities, people with learning disabilities, and also people from Black and minority ethnic communities, because we know that these people are also particularly at risk of being overweight and obese. So I'll leave it there, but I'm happy to take any comments and feedback about the draft strategy.
Okay, members, I have no show of hands. Is there anyone that would like to ask any questions or raise any comments? I mean, to me, that this has gone through, it went through Cabinet for approval to come out for consultation, and I think it's a very full and complete strategy. I think it's well put together. And it is a good document. What amazed me was the amount of information that you've got in Appendix D, the case studies and everything that's going on, underneath this. I also like the Veg Power in Leicestershire, what's going on there and the work's being done to date. So really good document. But I now have a couple of questions. Jeffrey, I'll go to yourself and then I'll come to you, Phil.
Yeah, I suppose, Chair, I'm the last person that should be talking or commenting on anything to do with obesity. I like food too much is the problem. But I see this and I just wonder, ought it not be part of this research or part of this policy to be looking at people with eating disorders? Because what concerns me is there seems to be this idea of a perfect body and a perfect weight, so you don't get COVID these days or anything else. But I keep on reading about various eating disorders, and I think that's a growing problem as well. It really is part of an overall package, and I think we ought to be researching and looking in as part of this becoming the perfect weight, looking into eating disorders.
Okay, Mike, I can see, I mean, obviously Liz is there. I can see, Mike, you've got your hand up as well, so I don't know if you can reply to this.
No, it's actually a question for Liz, funnily enough.
That's okay.
So I'll wait.
All right, thank you. Liz.
Yeah, so I think you're right that there are certainly people who have specialist needs in relation to eating, whether that be issues of anorexia and bulimia, and those very specialist services are included in that kind of middle bit, which is what are the services that we're providing in Leicestershire. But of course, the strategy is also a population strategy, so it's looking at the broader picture, and we know just how common overweight and obesity has become, with, as I said, 2/3 of adults in that category. The healthy weight range is evidence-based kind of range of what we know is it's not just one perfect ideal shape, but it's an indicator of where your risk will be lower for long-term conditions. There are nuances to that, so we know that where you carry your excess weight is important in determining your risk of long-term conditions. So if you carry your weight in the middle area, then you're more likely to develop certain conditions. So I think you're right. We do need to look at the eating disorders. There are issues associated with kind of increasing mental health problems, increasing with eating disorders, and we need those specialist services. But I think we also need to just look at the prevention and the whole weight environment as well.
Okay, thank you. Okay, thanks, Jeffrey. Phil.
Yeah, thanks, Liz. So there's a couple of things. So first of all, I don't know specifically about a lot about this, but I think apart from my own personal experience, and it's actually incredibly difficult. All of us at the moment, we're spending an awful lot of time sat in meetings like this, and I imagine doing exercise is rather difficult. Preparing proper, if I can put it in inverted commas, proper meals is rather difficult, because at the moment some of us have meeting after meeting after meeting, and the last thing you want to do whenever time you get around to having a meal is then spending some time in actually preparing that. It's actually quite difficult, and we all feel tired, and that's actually so I think it is, and lots of other people in the wider world and work are having to do that also, and I think it's quite difficult and challenging for everyone to do that. But I think what I would say about the strategy, I think it will need some revisions to take into account the lasting impacts that may exist in the marketplaces. For example, takeaway food and those sorts of things, because there are a number of strands, having read it, that for example, one of them was bring your grandparents into school to have school dinners. Well, obviously that can't happen at the moment, and so there are things there where maybe that's just a short-term thing. But so I think there is something in the strategy that maybe the short-term impacts of COVID might have an impact, but then are there some longer-term things which will then it needs to be adjusted to take that into account. The other thing is you touched on I think disabled people obviously being more at risk of not being able to exercise and things like that, but also carers. A lot of them are stuck at home, getting respite to enable them to go out and do exercise, whether that's just a walk around the streets where they live or anything, is quite difficult, because a lot of people at the moment are stuck at home and unable to do that. Again, whether that's just a short-term effect or whether that's a longer-term trend, I don't know. But finally, the only other point I wanted to make is one of the things which I didn't see if it touched on in the report was obviously one of the things you can do to help get people to take more exercise and therefore keep their weight under control is by designing better places for people to live. And that fundamentally comes back to the planning system, and ensuring that there are garden spaces in houses, that people there are good quality public open spaces, that there are play areas appropriate age for age appropriateness for children, for older teenagers, but also for adults to exercise outside. So there are all those things as well. And I'm sorry, I couldn't see if it was in the report. Maybe I missed the strand that it was called or something, but they were the points I wanted to make. Thank you, Chair.
Okay, thank you.
Okay, thanks. There's some really helpful points there. I think you're right about the carers, particularly over the last, sort of 8 to 9 months. There's probably a lot of pressure been put on carers, and not a lot of respite. So that's a good point, that needs to come out more. In terms of some of those actions, some of the examples that we gave, like the intergenerational eating, they're things that were happening. So we're doing quite a lot around obesity and healthy weight and sustainable food in Leicestershire. We have a food plan, and that's been looking at how we bring different sectors together and look at things like food sustainability. But obviously, all of these things need to be in the right, within the right kind of regulations at the time. I hope that it is a short-term thing, because they've shown through this intergenerational eating in care homes with bringing school children in that actually it's really beneficial. So with time and when it's safe to do so, that will be something that we would look at, safe return. But what we wanted to show in the strategy was some examples of the kinds of things that we meant, and these were things that were happening in Leicestershire, and there's also things we've identified that are not happening yet that we would like to see. In terms of the designing places, that's absolutely right, and that's part of that first theme. So the environment, the obesogenic environment, working with planners, working with district councils to look at planning policy and how we support active design in new housing developments, and I think there's examples from Blaby that where we've worked on a health impact assessment to look at are there opportunities to increase physical activity opportunities in this housing development, which is exactly what you're describing. So there's the Sport England produced a set of healthy active design principles, and we very much support those in when new housing estates are developed.
Okay, thank you. Mike, do you want to ask your question? Then I've got Andy, and I've still got Mr. Kaufman's hand up at the moment, so I don't know if it's gone up and gone down and come back up again. So, Mike.
Just recognise the Chancellor maintaining the public health grant, but it's a flat cash settlement, and I just wondered, Liz, if you'd like to comment on that, and is that an impediment to your ability to implement the healthy weight strategy? Well, actually, that's a serious point. Let's just take the freeze being a bad thing, but actually be interested to think about the balance between activities which do need grant funding and those that don't is probably the
that's what I was
nicer way of putting it.
That was going to be my nice answer, which is this is it's a systems strategy. This isn't about what public health services we can fund. This is about how do we work together across partners, which is why it's come to the Health and Wellbeing Board, to really make sure that we at all touch points with the public and all of our services, we can build these considerations in. There are some gaps in services that we've looked at and would need investment. For example, the very specialist, not the bariatric surgery, but the specialist weight management services that sit around that. At the moment, they're pretty rudimentary in Leicestershire, and so we need to look at how we address those.
Okay, thank you. Andy, would you like to ask your question?
Thanks, Joe. It's more of a sort of a comment really on the stressing from the medical perspective the importance of physical activity and healthy eating on people's longer term health, but not only just physical health, but mental health as well. And I think that's so important during the COVID pandemic as well, about how we try and keep people as well as we can. And I think this sort of project will pay dividends in the long term for the health of the people in Leicester and Leicestershire. I think that we can see that the impact of how certain schemes which would be, it doesn't necessarily have to be costly. For example, the introduction of kind of Joe Wicks at the start of the first pandemic, and the impact that had on the nation's physical activity was mind-boggling, really. And I think it's just bearing in mind that there are ways in which we can do things now that are maybe slightly different, but could really reach the public in ways that we haven't done before. I do think it's worthwhile making the just touching on the point about eating disorders. And although the two are linked in terms of the actual way in which people kind of use food in sort of in their daily lives, I think it is worth noting that eating disorders do carry an underlying mental health issue, which is somewhat separate from the behavioural choices that people make, and in terms of healthy eating and physical activity. So there can be an overlap, but I think it is worth noting that the physical activity and the healthy eating programs really are, for me, from my medical perspective, medical hat on, is more about kind of prevention and trying to encourage healthy behaviours to prevent a worsening situation in the future, rather than treating an existing eating disorder, which would come under sort of more mental health problems. Thanks.
Okay, thanks, Andy. Jeffrey, you've got your hand back up.
Yes, what I should have mentioned, and I really ought to mention as a district council representative, the district councils are big stakeholders in this exercise business and keeping fit. I mean, when you think the amount of money that we've invested in leisure centres, parks and various sorts of play equipment and everything going on like that. So whenever you draw up a strategy, it would be a bit of a waste of time unless you bring in and work with the districts. Because thinking, well, along as I sit here, I realise what our council, and I'm sure the other districts, have been doing to improve people's health with regards to exercise. And I see it particularly now because when you walk around, I've made more use of the local parks around here than ever before in my life. So got to include them in the strategy and work with them, because between you've got a big asset.
Okay, thanks, Jeffrey. Liz, anything you want to add at the end of that? I think there's no more. Oh, sorry, I've got a question from Christine.
Can I just, if it's okay, I'll just...
It's following on from that. It's not just the district councils, it's also the town and parish councils. They always have money from the S106 towards play equipment. And in Shepshed, we've just done a big thing in our park of outdoor exercise equipment that's really well used. So I think it's, sometimes we seem to forget the towns and parishes that do quite a lot of promoting this type of thing as well. Sorry, but I just have to say that as well.
Thank you. Liz?
Yeah, no, I was just going to follow up really to say that whilst there isn't a huge amount of emphasis on physical activity in the document you've read, that's because it's running alongside the physical activity strategy that is developed by Leicestershire and Rutland Sports, who are our active partnership in Leicestershire. Jane will know we work incredibly closely with all of the district councils on sport and physical activity. Every year we go through a kind of annual planning cycle of looking at what the priorities need to be, and then looking at both what the public health commissioning kind of funding can do, but then also how that's complemented by funding from other sources and from the district council's own income from leisure services and their own kind of activities. So I can assure you, and I hope Jane would agree, that we do try to work really, really closely with the district councils, particularly around physical activity. But we've also been doing quite intensive work looking at the what we can do around planning. We worked very closely with Hinckley and Bosworth in a project to just scope out, well, what is the planning process and what are those opportunities to influence physical activity, and that has informed our health impact assessment approach, and again working with Leicestershire and Rutland Sport to kind of roll that out to other districts. In terms of town and parish councils, again I agree, the section 106 money and the strategy of how we, where we need kind of equipment and playing fields and other facilities is an important part of it, and I would agree with that.
Okay, thanks, Liz. I have no more questions. If Christine and Jeffrey would like to lower their hands, the consultation ends on the 27th of December. It's an 8-week consultation, so we are asked to comment on the draft health strategy as part of the consultation process, which I think we've done. So hopefully we've got plenty of comments from members there that we can put as our views on that. So can I thank you, Liz, for your presentation and your report, and thank you.
Thanks.
Next item on the agenda is a report on the Leicestershire Children and Families Partnership Plan 2018-21. It's a progress update which is covered on pages 71 to 78. This report presents the board with an update on the Children and Families Plan. Mala is who's the partnership manager, has joined us to present the report. So Mala, if I can hand over to yourself. I know Jane Moore has had to leave the meeting for another meeting, but I'll take questions afterwards. So thank you.
Thank you, Chair. As you've outlined, I'm here to present a progress update on the Children and Families Partnership Plan and to present proposed revised terms of reference for the Children and Families Partnership Board for your approval. The current partnership plan, a 3-year plan, is due to end in March 21. As you'll see from the report, the new chair of the partnership, Councillor Taylor, requested that the leads for each of the 5 priority areas of the plan review their action plans in readiness for the April 21 refresh, and also to take this opportunity to consider any additional actions needed in response to the current COVID-19 pandemic. The action plan included in the report as Appendix A was presented to the Children and Families Partnership Board at their meeting in November and was approved, pending some additional actions to be added in relation to Priority 5 that will be developed around children's mental health through the new Children's Design Group, and pending the agreement of the proposed actions in Priority 3 by the Early Help Partnership in December. The partnership have agreed that the existing 5 priority areas remain very relevant and pertinent. So the action plans have been built around those existing 5 priorities. The proposed action plans that have been presented here are actions that the partnership and the priority leads feel would be very relevant for the coming year and possibly even further. The proposal is we would review at the end of each year and amend actions or add actions as needed. Progress against the delivery plan has continued over the pandemic period. However, as we can imagine and we would expect, there has been some impact in terms of delays, particularly where lockdown prevented certain actions being moved forward. The report highlights some selected areas of progress against each of the 5 priorities, and we would like to ask you to note the progress update. As I've mentioned, in terms of Priority 3, that is still a proposed action plan as a new action plan that we will be presenting to the Early Help Partnership in December to agree as their action plan moving forward. And in relation to the terms of reference, the partnership also identified the need at this time to update the terms of reference to recognise the strategic alignment of the Leicestershire Education Excellence Partnership, the Send and Inclusion Board, the Youth and Justice Partnership Board and the Early Help Partnership as subgroups who will now be asked to provide regular progress updates to the Children and Families Partnership. The draft terms of reference were approved by the Children and Families Partnership Board in their meeting of November and have been attached as Appendix B for approval by the Health and Wellbeing Board, with a minor amendment in relation to the first page, point B, where we just need to amend the wording from child sexual exploitation to child criminal exploitation. It was an oversight that we didn't make that change in the paper that was sent to you. So that's just a brief overview, and I'm happy to take some questions if needed. And Councillor Taylor, I can see, is on the call as the chair of the partnership, who may also be able to respond to the questions.
Okay, thank you, Mal. I was going to say, Deborah, is there anything you just want to add before I open it up to questions? I've got no hands up at the moment, but if you want to add any comments or thoughts.
Thank you, Chair. Obviously, I've been involved in this in my previous role as the Cabinet Support Member, but when I moved in, it was just really, for me, it was the last plan was quite busy and quite complex for me, and I just wanted to get some more focus, really, and move stuff off that's embedded into practice now. So I'm hoping you like the new format and the new, more simplified and less complex and a lot less words on the plan. But no, I'm really happy the way it's looking, and with some new people on board as well, some fresh eyes. I think it's really moved forward. And no, I'm happy to take any questions though, Chair. Thank you.
Okay, thank you. Phil, you have a question.
Yeah. So just thanks, Debbie. The diagram at the end is quite helpful to understand the relationship of this board with the Health and Wellbeing Board, because there does seem to be a plethora of boards which seem to report to the Health and Wellbeing Board, this being one of them from what I can understand. So what I just wanted to clarify is There's obviously representatives from lots of different partners on this group, but there doesn't seem to be a district member represented on this group. I know there's a district officer, but I'm just wondering what the rationale is for that, or whether there is a rationale that could be made for. And what I was thinking here, because a lot of this work seems to be connected with cross into things like community safety areas where, you know, and that sort of area of work. And I'm just wondering if that's something where districts have quite a clear role for, whether a district lead member should be perhaps represented on this. It's just a thought. Anyway, thank you, Chair.
Thank you. I was going to say, if someone would like to, Jane, you've got your hand up. Do you want to come back in on that? Because I think there is representation on the various levels of board from districts. But yeah, Jane, if you just want to.
Thanks, Lee. Really, just to respond to Councillor King there, that we did have that discussion. Julia Smith from Harbour actually is the lead for this, and her feedback is into the organisation, and actually it does go back into respective community safety partnerships, for example, and obviously here where there is member representation. So it was discussed and actually felt that it wasn't appropriate at that level, because the work that the rep takes back is all work within the district where members should be fully engaged within their own organisation. So.
Okay, thanks, Jane. Okay, Phil, thank you. I have no other questions, so the board's asked to note the progress and approve the Partnership Board's revised terms of reference. Mal has obviously highlighted the one amendment which we note, and obviously that will go through in the new terms of reference, but are members of the board happy to approve the Partnership revised terms of reference? Okay, I can see everyone said that there's no hands waving at me or anything like that, so I'll take that as a positive. So can I thank Mala for her presentation, and good luck with taking it forward, so, and all the work that's going on, so thank you.
Thank you.
Item 9 is to present the revised terms of the reference for the Integration Executive, which sit on pages 89 to 107. This report asks the board to approve a revised set of terms of reference for the Integration Executive, which is one of our subgroups. John Wilson is going to present this item for us, so hand over to you, John.
Thank you, Chair. So yes, I'm here as a representative and a member of the Integration Executive to bring forward the revised terms of reference. Integration Executive is one of the 3 groups that reports into the Health and Wellbeing Board, as was just shown on the previous slides. The Integration Executive has been in place for a number of years and oversees the day-to-day delivery of integration of health, housing and care across Leicestershire. We've been reviewing and revising the terms and conditions over the course of the last couple of months, really to reflect 2 things. One is the new strategic priorities that have been agreed at the system level, and thinking about how they relate to the work we want to do across the Leicestershire place. And secondly, to consider the changes in partner organisational arrangements that have taken place over the last 12 to 18 months. So paragraph 7 of the report details the main areas of change to the terms of reference, which just reflects those 2 things that I've been talking about there. There are some changes to the membership. One of the changes that we've made is to have more presence on the Integration Executive of clinicians. So we've invited PCN directors, clinical directors, onto the Integration Executive. Reflects back on the report we had earlier in the Health and Wellbeing Board this afternoon. And then just for completeness, we've also attached the terms of reference for the various groups that support the Integration Executive. So there's a joint commissioning group, an integrated delivery group, and an integrated finance and performance group. And they're just there for information. So happy to stop there and take any questions, Chair.
Okay, thanks, John. Jane, you've got your hand up, so I'll ask you first. Phil, is your hand up still from the last session, or have you got a question on this one as well? Okay.
Hang on, it was, Chair, but I have got a query.
Phil,
I'm happy for Jane to go first.
Thank you. That's what I was going to say. Thank you very much, Jane.
Thank you. Just a quick comment there, whether it should really reference housing related support services. It's just a technicality, really. And then just as a follow on from that, I wonder, just in terms of representation, whether it should really specifically, and it does, I just wonder if it could be tweaked to specifically reference light bulb in the context that light bulb is, of course, through the HEC project, a recipient from the BCF. So it's just those small points, really. Thanks.
Okay, thanks, Jane. Okay, Phil.
Yeah, sorry. Perils of having a touchscreen laptop. Right, the query I'd got was just in the terms of reference under the chairing. Now, somebody earlier on in the meeting said the CCG is now one CCG. So it says the chair shall alternate every 2 years, particularly the clinical chair of West Leicestershire CCG and the clinical vice chair of ELR CCG. Are they actually still pertinent organisations? That was my query.
Okay, well, I'll give you my response, but other colleagues may be more informed than me. As far as I'm aware, both organisations are still organisations in their own right. We have an aligned CCG management structure and we have aligned commissioning arrangements across the CCGs, but the two bodies are organisations in their own right and have their own governing bodies, is my understanding.
Okay, Dr. Sangani, do you want to add to that?
Yeah, just absolutely concur with that. So I think the point made earlier on by Laura, our colleague, was to sort of describe how we work in much more collaborative, as though we're one organisation, especially during the pandemic. But yes, we do have two governing bodies and we're two separate organisations currently.
Okay, thank you.
Okay.
Shall I just respond to Jane's point, Chair? I think, you know, if the board are happy to accept those revisions that Jane's put forward, see no reason why we can't make those alterations and take that forward with the board's approval.
Okay, I have no further questions. Are board members happy that we are asked to approve the revised terms? So you've heard the comments that John's just made on the points that Jane raised. So with that, are members happy with the terms of reference being revised for the integration executive? So yes, I'll take that as yes. Thank you, board members.
Agreed.
Thank you, John. Thanks for presenting that. Item 11 is item 10. Let's get it right. Item 10 is the Health and Wellbeing Board Governance, pages 109 to 114. This report presents a revised set of terms of reference for the Health and Wellbeing Board ourselves here. And I'll hand over to Matt, who's going to our Democratic Services Officer, who will talk us through the document presented. So, Matt.
Thanks, Chair. The revised terms of reference, which have been presented to the board for approval today, incorporate a small number of minor changes to reflect the discussions at a previous board development session. Wording in several parts of the document has been altered to emphasise the board's focus on place-based outcomes and delivery against the Joint Health and Wellbeing Board strategy. Reference to an outcomes framework has also been added, and that will measure performance against the priority outcomes. The membership has also been amended to include an additional non-clinical representative of the clinical commissioning groups. Happy to take any questions, Chair.
Okay, thanks, Matt. Do members have any questions regarding what we're being asked for today on the revised terms? I've got no one showing, so I take that as everyone being happy with what is presented to you. So I think it does refresh them as well. So we're asked to approve the revised terms of reference for this board. Are members all happy? I'll take that as a yes. Thank you ever so much. Thank you, members. Item 11, for information, for members' information, the date of future listings, meetings are listed under item 11. I understand and I know that as board manager, Joe's been gathering views across members on developing the board moving forward. And one of the first steps was to reduce the frequency of the meetings from 6 a year to 4, which I think is a good move, and with additional development sessions held as required. So the dates were given in the paper, Thursday the 28th of January next year, 27th of May, the 8th of July and the 25th of November, which will fit in with everything else that we have and we try and sort of get updates on at the board meeting. So for information, those are the dates based on what we told Jo when she did her sort of investigations talking to you all. So thank you for that, members. And item 12, which I've already covered, any other urgent items which I was asked to take as urgent. There aren't any urgent items. So can I just thank all board members for your work? I mean, the people around the table here are the people that are delivering during the current pandemic, and thank you. It is appreciated, I think, certainly by all the people in Leicestershire, and I know the city and Rutland would say the same. So can I thank all members and officers here today, and also any visitors that are online with us. I think because we're in November, it's too early to wish people a happy Christmas, although it seems to have been around for a long time. But I'd just ask everyone to stay safe. Please do have yourself a good Christmas, and thank you ever so much. Look forward to welcoming you to the next board meeting in the new year. So thank you all.
Thanks, Lee. Bye.
Thank you.
Thank you, Chair.